Let's start with the second slide. I'm going to talk to you about the 2016 seed objectives from NHS England. They haven't been set, so that's it. Nice to see you all. Enjoy the rest of your day, and I'm sure it'll be particularly good. So what I'm going to talk about, I'll talk about a bit of reflections and some of the history and some of the bits that are going on at the moment. Whilst the objectives haven't come out, it won't surprise you to know they're not markedly different. They do come out in the next few weeks to how they've been already, so that won't be a surprise. So a quick bit of background. We will always have C. diff infection. If you think for one moment that it's going to disappear totally, you need to think again. And the reason is because C. diff is an organism. It's found everywhere in the environment, in the soil, in the water, and certainly carried asymptomatically. And it's estimated up to 7% of people will actually sort of carry it. And it will actually occur outside of the healthcare environment. And we'll look at some figures a bit later on here. And I think as we start to see more and more cases of C. diff actually occurring in the community, we really need to start to think about different ways about how we will end up sort of tackling C. diff outside of sort of the hospital environment. So every year, NHS England, having taken advice from RHI, who are the Department of Health Antimicrobial Resistance and Healthcare Acquired Infections advisory group to the government, will actually publish some C. diff objectives for acute trusts and CCGs. And these are actually calculated on the basis of requiring continuous improvement. There's also given some guidance for organisations with higher rates of C. diff, perhaps to do more work to try and improve where they are than those with lower rates. We also give guidance on commissioners, how they can actually exercise discretion to impose sanctions on providers for breach of objective. And I'll explore this a bit more in a moment. And then certainly to take into account of specific circumstances related to infections, whether sanctions are actually appropriate or not, and we'll explore these. So a bit of history. This was a headline from the Daily Mail in 2008 after we had a series of outbreaks of C. diff in various sort of hospitals, and the headline was all about C. diff superbug kills one patient in British hospitals every hour. And this is something I'm not particularly sort of proud of. I was in Leeds, and I remember we used to have 80 C. diffs a month in there. And if you think of the 1 in 6 patients who actually has C. diff infection dies within 28 days, that is something none of us in healthcare can be proud of. And this is why, from 2008, we actually had targets set to try and improve the care of our sort of patients. And I don't know if any of you saw the Panorama programme in 2008 about how safe are our hospitals. It didn't make for particularly good viewing. The good news, though, is actually we've made some pretty sort of big sort of strides on the way forward. And the reason this mainly happened was there were actually fairly large financial sanctions to try and get us to improve our cleaning, our prescribing, and our general sort of care of patients. And you can see if you exceeded your C. diff objective, there were fines for up to £50,000. And certainly my organisation was fined over £5 million on one occasion. And so it had a really big impact. The really good news is we've actually increased the amount of C. diff infections by 74% since 2008. And during that time, most of them were mainly hospital onset and healthcare associated. But you can see on here how we've seen that sort of year-on-year sort of reduction of 15% and almost 1% month-on-month. So that's a good news story. So from April 2004, what we did is actually to try and have a slight sort of change of sort of focus on here. And what we tried to get NHS Acute Trust to do were to identify if actually there had been a C. diff infection connected to a lapse in care. And we actually provided a checklist, and I'll talk you through this in a while. And then only cases associated with lapse in care should actually be considered for inclusion in calculations for financial sanctions. And I'm hoping when we have time for questions later, we might have a bit of a discussion about that and the impact that it's done. And the reason we made the changes is because year on year we'd seen very large declines in sort of the numbers sort of on there. And there were certainly organisations out there who probably reduced their C. diff infections to probably an irreducible minimum level. So there was no point in actually really trying to drive on something where we were probably going to sort of fail. And so there was a formula for setting up what the targets would end up being, and I'm sure many people could probably criticise it, but this is the way it is. And so for non-teaching acute trust, it was a 12% reduction. The teaching acute trust was 13.5%, and CCGs, it was an 8% reduction. And if you were already at the, in that sort of cohort, your new rate was just one less. However, if you were worse than the cohort, it was whatever your current rate was minus the actual cohort reduction that was sort of going on there. And the fines actually moved from 50,000 per case over to 10,000 over the objective. But there was a big change in there, which was about you ended up having to test and report all of those positive specimens. And that really had a bit of change sort of going on there to try and get rid of some of the gaming which was actually taking place. So this is the lapse in care checklist, which I would have thought would have been fairly self-explanatory for trying to find lapses in care. And I'll show you some data from the London region in a moment. So, did patients have diarrhea admission? Did you identify the risk factors, whether it was medicines they were on or conditions? Did we actually record the bowel habits on admission? Did we start using Bristol stool chart straight away and put them into isolation? Did we follow the correct sampling? What about the patient pathway over the last 3 months? Where had they been? Had they been home? Had they been to hospital? Had they had contact with carriers? If it was a recurrence, did we follow the correct guidance the first time we were treating them? What about other contributory factors? Did you follow local guidance? So if they were on a proton pump inhibitor, was it following the guidance you had within that health economy? What about antimicrobial therapy over the last 3 months? Were you following the guidelines? Was there an indication on prescriptions? Was it the appropriate duration? Were patients being de-escalated as soon as you got sort of results back from the lab? And then the treatment of CDI, was there actually, was the severity of the CDI recorded? Did it follow the guideline? What about the outcome? I've already said about 1 in 6 patients were dying from their C. diff. Was it recorded on the death certificate? Was the patient actually informed that it was C. diff? And did they actually understand what it meant? What about the environment? What were the hand hygiene scores, cleaning scores? Had there been deep cleans taking place? What about organisational thing? Was the right number of staff around? Were people up to date with their infection prevention control training? Was there any problems with communication, documentation? Did the organisation actually optimise diarrhoea management within sort of the hospital? And were there recurring themes? Were we learning from the sort of lessons from previously? And then finally, was it preventable? And was it a potentially no lapse? So if we look at this here, this is the actual sort of the rates that we are seeing on here. And I don't know if you can see here, this is the 14-15. And for the first year, you can see it's gone slightly upwards here. And we saw a 6% increase in that sort of year going on. And then the first 2 quarters during this current year, we've actually seen a 1% sort of increase, but it's not within the sort of the trust going on here. And the objective this current year was a rollover from 14-15, so we realised that there was work to do. Now, Russell Hope showed you this earlier about where all the C. diff sort of cases were taking place. And for a long time, they were very much, which is showing up here, which is very much healthcare sort of on set in here. And now it's only about 40%. Whereas those who get tested in the first 48 hours are in hospital, or they get a positive test the 4 weeks after discharge, there's usually sort of onset on there. And then we have something in that sort of 8 weeks, so from weeks sort of 5 through to 12, which is 11% sort of on there, which is growing, and then those which are purely community onset and they've had no sort of connection to sort of healthcare at all, which is almost 20% and actually is growing sort of on there. So if you think about the bits that's very much hospital focused, it's only about 40% at the moment. Okay, so bear in mind about 40% is hospital attributed, and the rest is actually out in the community. What's really sort of happening? So this is some work that Sally Kingsland has actually shared with me and found to share with you. She's done a survey in London, and she's got some feedback from CCGs and 16 acute trusts. Now, 60%, 9 out of 16 acute trusts reported their C. diffs were actually above the threshold. And out of the 671 cases reported C. diff, only 14% agreed that there had been a lapse in care. So that's 86% where there wasn't any lapse in care. And if you think about the checklist I showed you earlier, I certainly know in my organisation, we certainly get nowhere near 86%, have no lapses in care on there. You can see the range between 0 and 50%. And 37% of trusts said there had been no lapses in care. I suppose the good news in many ways is there haven't perhaps been the financial sort of penalties that have been imposed sort of on there. And one of them hadn't followed the lapse in care process last year, but they were this year. Okay, what about the community C. diff cases? Remember I was saying it's over 60% now? So they'd asked what was happening on there, and they'd actually response from 26 out of 32 CCGs from, based on earlier this month. So 2 CCGs were only looking at serious incidents, 5 were looking at cases relating to community inpatient facilities, 6 said they had no process in place, 1 said they had not been notified of any cases, 2 CCGs said they had problems with information and governance, 2 said they actually had a comprehensive process, so that's 2 out of the 26. And then 2 CCGs said they were gathering broader insights about what was going on. So I think it's time to actually try and come up with a bit better model that's sort of going on in there. So this is an example I've been allowed to share with you from South Hampshire. And the Ship region basically has 8 CCGs, 7 acute trusts, 2 community trusts, and has a population of just under 2 million. You can see there's a fairly broad range here of C. diff infection rates on here. And what they've done is they've set up a joint appeals panel, and basically all cases are heard within this collaborative at the moment. There's a single submission using local paperwork and a checklist. There's equity that takes place, so providers can expect to receive consistent and equitable judgments. There's transparency, so everyone's clear about the decision making, and there's some expertise that exists in there. And who sits on this? Well, there's a joint appeals panel, and you can see who sits on there. So there's representatives from Infection Prevention Control, Medicines Management, Public Health England, NHS local area team, the Deputy Director of CCG, and then providers, microbiologists, consultant pharmacists, antimicrobials, and the Council of Public Health, and the CCG sort of quality managers. And so what have they found out here? So the themes mainly here, so they looked at the time of 24 submissions, and only 58 of them had no relapse. Mainly about risk assessment, a bit around antimicrobials sort of going on here, and isolation on here. But one of the key bits for this is that all providers are actually invited, so there's senior nursing, senior medicals, they stay for the whole panel, so they don't just listen to their own, they listen to other people's cases on there. But for me, the important bit is at the bottom bit. So this bit here, providers have to give a summary of the lapses in care cases that don't reach the panel, so we can actually have some learning to take place. And I think that's the most important bit there. So in summary, we haven't published the objectives yet. We know that since 2007 we've seen a 74% reduction in C. diff, and certainly it's plateaued over the last year and a half. Hospital onset CDI have dropped markedly, and we're certainly seeing more sort of community onset cases. We're seeing wide variation in lapse and care implementation, the review of outcomes, and I think a collaborative review model might actually allow better learning and consistency of approach. And one of the things you'll start to see from April is very much this local AMR approach. So instead of just focusing on MRSA and C. diff, you'll see on using GP fingertip system, you will actually see all the data about all the stuff that we've heard about today in a central place. So we can have whole health economy discussions about how we can actually improve the care of our patients. Thank you very much.